Your doctor tells you your HbA1c is 7.1. You nod. The appointment moves on. But nobody explains why your blood sugar still swings from one day to the next. Nobody explains why you can eat the same meal on Monday and Tuesday and get completely different readings. Nobody explains why your fasting number this morning was higher than when you went to bed last night. Despite not eating a single thing overnight, you are following the advice. You are taking the medication. You are watching what you eat. And yet something about your blood sugar still does not fully make sense to you. If that description fits, this video is for you. Because what I am going to cover today is not the standard diabetes information. It is the layer underneath it. The physiological realities of blood sugar management after 60 that a 10-minute appointment covers either briefly or not at all. Not because your doctor does not know them, but because the system does not give them enough time to explain them properly. My name is Dr. Henry Mercer. I am a specialist in aging medicine with over 20 years of experience working with adults over 60 managing conditions exactly like this one. Everything I share on this channel is designed to complement the care you receive, not to replace it. Your physician knows your history, your medications, and your specific case. What I can give you is the deeper explanation that appointment rarely has time for. There is one thing in particular about your muscles and your blood sugar that almost nobody explains to diabetic adults over 60. Once you understand it, years of confusing post-meal readings will finally make clinical sense. I have shared it with patients who have been managing this condition for decades, and the response is consistently the same. Nobody has ever explained that to me before. Stay with me. You will understand why before we finish. And before we close today, I'm going to give you 5 specific questions, not generic ones, that will change the clinical conversation at your very next diabetes appointment. Before we get to the 5 insights, I need to give you one piece of context that reframes everything that follows. Blood sugar regulation after 60 is not the same physiological process as blood sugar regulation at 40, or even at 50. 3 things change with age that directly affect how your body handles glucose. Insulin sensitivity decreases, meaning the body requires more insulin to move the same amount of sugar out of the bloodstream. Kidney glucose handling changes, affecting how efficiently excess sugar is cleared. And the hormonal responses that normally signal the body to regulate blood sugar become less precise and less rapid. These are not small adjustments. They are fundamental changes to the underlying system, which means this. The advice you were given may have been accurate for a 45-year-old with type 2 diabetes. You are not 45 anymore. And the physiology has changed in ways that a standard diabetes management plan, built around general guidelines rather than age-specific physiology, may not fully reflect. That is what today is about. Everything I share today works alongside your medication and your physician's guidance, not instead of it. If anything in this video raises questions about your specific management plan, those questions belong in your doctor's office. That conversation is exactly the one this video is designed to help you have. The first thing your appointment rarely addresses is a blind spot in the most commonly used measure of diabetes control, HbA1c, the number your appointment opens and closes with. HbA1c measures the percentage of hemoglobin in your blood that has glucose attached to it, reflecting your average blood sugar over the previous 90 days. It is a genuinely useful number. It is not, however, a complete picture. Here is the problem. It is an average. Imagine 2 drivers who both average 60 miles per hour on a long journey. The first drives at a steady 58 to 62 miles per hour the entire way. The second alternates between 20 and 100, repeatedly. For the entire journey, the average is identical. The experience and the wear on the vehicle is completely different. 2 patients can have an identical HbA1c of 7.0. One has stable blood sugar that moves within a moderate range throughout the day. The other has blood sugar that spikes dramatically after meals and drops sharply between them, but averages out to the same number. Same HbA1c. Completely different physiological experience. Research increasingly suggests that blood sugar variability may contribute independently to cardiovascular and cognitive risk beyond what HbA1c alone can capture. Consider it this way. One patient spends most of the day between 90 and 140. Another repeatedly spikes above 220 after meals and drops sharply before the next one. On paper, they can finish with the same HbA1c. The average looks identical. The daily experience and the physiological load is completely different. The clinical term for what the HbA1c misses is glycemic variability. And there is a more informative measure called time in range, the percentage of time your blood sugar spends within a healthy target window rather than above or below it. For most patients managing diabetes after 60, this distinction has never been explained in a standard appointment. The appointment looks at the average. Time and range looks at the journey. For aging physiology, the journey matters enormously. This is the first conversation worth having at your next appointment. We will come back to the exact question to ask. The second insight is the one I mentioned at the beginning, the one that consistently produces the response. Nobody has ever told me this before. I want you to understand something about your own muscles. Skeletal muscle, the muscle in your legs, your arms, your back, your core, is one of the body's most important sites for glucose uptake after meals. When you eat a meal and your blood sugar rises, your muscles play a central role in absorbing that glucose from the bloodstream. This means your muscle mass is not just a measure of physical strength. It is a direct measure of your body's capacity to clear blood sugar after meals. Now here's the part that almost never reaches a standard diabetes appointment. After the age of 60, skeletal muscle mass declines at a rate of approximately 3 to 5% per decade without active intervention. This process has a clinical name, sarcopenia, and it progresses quietly, without obvious symptoms, while its metabolic consequences accumulate steadily. Less muscle mass means less glucose uptake capacity after meals, which means blood sugar stays elevated for longer after eating, which means the post-meal spikes become more pronounced, more sustained, and harder to manage, even when diet has not changed, even when medication has not changed, and even when the patient is doing everything they were told to do. This is why post-meal blood sugar can worsen progressively in a diabetic patient over 60 whose diet and medication have remained constant. The glucose disposal capacity has changed, and nobody explained that the capacity was changing. A patient I see regularly, a 74-year-old man who had managed his diabetes carefully for 11 years, came to me frustrated. His diet was disciplined. His medication compliance was excellent. But his post-meal readings had been climbing steadily for 2 years, and nobody had explained why. When I explained the muscle mass mechanism to him, he was quiet for a moment. Then he said, "That is the first thing in 11 years that has actually made sense of what I have been seeing. Here is the actionable part. And this is the part I want you to remember above everything else in this video. 10 minutes of light, physical movement after a meal, even a short walk around the block, even gentle movement around the house, activates muscle glucose uptake through a mechanism that is partially independent of insulin. The muscles begin absorbing blood sugar from the bloodstream simply because they are being used." In clinical research, post-meal walking of just 10 to 15 minutes has shown consistent and meaningful reductions in post-meal blood sugar spikes in diabetic adults. This is not a fitness recommendation. This is a blood sugar management strategy. A specific, targeted, evidence-based intervention for the exact physiological problem that aging creates, and one that almost no standard diabetes appointment takes the time to explain. Preserving muscle mass through regular resistance activity matters for the same reason. Every pound of muscle preserved is glucose uptake capacity maintained. For a diabetic patient over 60, building and maintaining muscle is diabetes management. That is the insight the appointment does not have time for. The third insight explains a specific experience that confuses many diabetic adults over 60, and that most standard appointments never address directly. You go to bed with a reasonable blood sugar reading. You wake up and your fasting number is higher than when you went to sleep. You have not eaten anything overnight. Nothing has obviously gone wrong, and yet the number is worse than it was 8 hours earlier. Most people assume they did something wrong. Often they did not. What they are experiencing has a clinical name, the dawn phenomenon. And it is more pronounced in adults with diabetes after 60 than in younger diabetic patients. Here is the mechanism. In the early morning hours, roughly between 3 a.m. and 8 a.m., the body releases a natural surge of hormones, including cortisol and growth hormone, as part of its preparation for waking. In a person without diabetes, the pancreas responds to this hormonal surge with a small compensating insulin release that keeps blood sugar stable. In a person with type 2 diabetes, that compensating response is impaired. The result is that the liver releases stored glucose in response to the hormonal signals, blood sugar rises, and the patient wakes up with a higher fasting reading than they went to sleep with. Sleep quality amplifies this directly. The fragmented, lighter sleep that is extremely common after 60, waking in the night, shorter deep sleep cycles, early waking, increases the cortisol release during those early morning hours. More cortisol means a more pronounced dawn effect, which means consistently higher fasting readings than the patient's medication and diet would otherwise produce. The practical implication is significant. For a diabetic senior whose fasting blood sugar is consistently elevated, sleep quality is not a separate wellness concern. It is a blood sugar management variable. a direct one, and improving sleep quality through specific, evidence-based sleep hygiene rather than medication, has shown measurable impact on fasting blood sugar in clinical research. This is worth a specific conversation with your physician, particularly if your fasting numbers have been consistently difficult to manage despite appropriate medication. The fourth insight is one I want to frame carefully, because it touches on medication, and anything involving medication deserves precision. Have you ever felt that a medication schedule that worked well some years ago does not seem to produce quite the same results today? Many patients assume their diabetes is simply getting worse, that the condition is progressing, that nothing can be done about it. But there is another possibility. The body that medication is working inside has changed, and that change has clinical implications for how treatment works in practice. Here's the specific mechanism. One age-related change that can occur is slower gastric emptying, meaning food may move more slowly from the stomach into the digestive system than it did earlier in life. As a result, glucose from a meal may enter the bloodstream more gradually than it once did. This means that after 60, the glucose from a meal enters the bloodstream more slowly than it would have at 40. The peak blood sugar response to the same meal arrives later than it once did. For some patients and some medications, age-related changes in digestion and meal timing may influence how treatment schedules are best individualized. This is not a universal statement. It depends on the specific medication, the individual's physiology, and their eating patterns. But it is a dimension of diabetes management after 60 that is worth raising with your prescribing physician. I am not suggesting you change your medication timing. That is a conversation for your prescribing physician, who knows your specific medications and your specific clinical picture. What I am saying is that this conversation is worth having. Specifically, asking whether your current medication timing has been reviewed in the context of your age and your meal patterns. That question will either confirm your current timing is well calibrated or open a clinical discussion that could improve your management. The reason most patients have never had this conversation is simple. Optimizing medication timing to individual physiology requires more than 10 minutes, so it often does not happen unless the patient initiates it. The fifth insight is brief, but clinically real, and I want to keep it focused on the physiology rather than the psychology. Chronic stress raises blood sugar, not through behavior, not because stressed people eat differently, though that is also true, but through a direct physiological mechanism. Cortisol, the primary stress hormone, signals the liver to release stored glucose into the bloodstream. This is an evolutionary survival mechanism, preparing the body for physical response to threat. In a person without diabetes, the insulin response manages that glucose release efficiently. In a person with type 2 diabetes, the impaired insulin response allows that cortisol-driven glucose to accumulate in the bloodstream. For a diabetic adult over 60 who carries chronic low-grade stress, the health anxiety of managing a long-term condition, concerns about independence, family pressures. This is not a small variable. It is a consistent, daily, physiological contribution to blood sugar elevation that operates entirely independently of diet and medication. Some studies have shown modest improvements in blood sugar control when stress reduction practices are used consistently alongside standard diabetes treatment. 10 minutes of calm, focused breathing, a short walk in natural light, a consistent wind-down routine before sleep. These are not alternatives to medication. They are physiological tools that may help reduce the cortisol load working against your medication's effectiveness over time. Managing stress is managing blood sugar. In the physiology of diabetes after 60, those two things are not separate. Let me show you the complete picture these 5 insights create together. Your standard appointment manages one primary metric, HbA1c, with one primary tool, medication. That is not wrong. It is simply incomplete. And the issue is rarely a lack of knowledge. More often, it is the reality that modern diabetes care must fit complex, age-specific physiology into a very short appointment. That constraint is what this channel exists to work alongside. The complete management picture for diabetes after 60 involves 5 interacting variables. Glycemic variability, what your blood sugar is actually doing between the averages. Muscle mass, your body's primary glucose disposal capacity. Sleep quality, a direct driver of fasting blood sugar through the dawn phenomenon. Medication timing, calibrated to aging physiology rather than general guidelines. And cortisol, the stress-driven glucose release that works against your medication every day it goes unaddressed. None of these are alternatives to your medication or your physician's guidance. They are the surrounding framework that determines how effectively your medication works. And each one is within your influence in ways that a standard appointment rarely has time to explain. You are not failing to manage your diabetes. You are managing it with an incomplete map. This video is the rest of the map. Here are the 5 questions I want you to bring to your next appointment. These are not generic questions. They are specific enough to signal clinical knowledge and open a more detailed conversation. 1. Beyond my HbA1c, can we discuss my time and range? And would a continuous glucose monitor help us understand my blood sugar variability more clearly? 2. Given my age and the natural decline in muscle mass after 60, should post-meal physical activity be part of my formal management plan? And what level of activity would be appropriate for my situation? 3. My fasting blood sugar is sometimes higher than my bedtime reading. Could the dawn phenomenon be contributing to this? And is there anything in my current plan that addresses it? 4. Has my medication timing been reviewed in the context of how gastric emptying changes with age? And is there any value in discussing whether my current timing is optimized for my meal patterns? 5. To what extent might chronic cortisol elevation be affecting my blood sugar? And are there specific evidence-based approaches you would recommend for addressing that in my situation? Each of these questions does 2 things simultaneously. It demonstrates that you understand your own condition at a clinical level, and it opens a conversation that 10 minutes of standard appointment time rarely reaches on its own. Tell me in the comments, when was the last time your diabetes appointment covered any of the 5 things we discussed today? I read every comment, and the answers genuinely shape what this channel covers next. One important thing before we close. Everything discussed today works alongside your medication and your physician's guidance, not instead of it. The post-meal walking, the sleep improvements, the stress management practices. These are complementary tools, not replacements for prescribed treatment. Any changes to medication timing must be discussed with your prescribing physician before being implemented. Your doctor knows your complete clinical picture. This video provides context. Your appointment provides care. You have been managing this condition faithfully, often for years, sometimes for decades. You deserved a fuller explanation of what was happening in your own body long before today. Now you have it. And the next conversation with your doctor will be a better one because of it.